Thank you, Chairperson. Thank you, delegates, for being so early and on time. I'm going to go on to another topic which extends from thrombectomy. Can we have the next presentation? This is routinely we see in our practice, and especially with PAMI being the therapy of choice. And most of our patients, as we know, generally come to us late. In India, you don't have a patient coming within the golden hour where it's very easy. You might not see too much no reflow. So what do you call an angiographic no reflow? It's basically a TIMI 0-1 flow in absence of dissection, spasm, stenosis, or thrombus. Is generally seen in unstable coronary syndromes, MIs, acute coronary syndrome. But bear in mind, it can also happen in chronic stable angina. The no reflow phenomenon is seen in approximately 30% of AMI patients who are treated with primary or rescue angioplasty and can have potential adverse outcomes. The pathophysiology, as we know, is due to damage to the microvasculature. The mechanisms that they propose is one is endothelial dysfunction, plugging of small vessels, compression of small vessels by tissue edema, and thrombus and debris dislocation. So that's the plugging with platelets, neutrophil plugs, tissue edema, and microembolism. Distal embolism of debris and thrombus does matter. How do we diagnose these things? Myocardial contrast echo, myocardial scintigraphy, cardiac MRI, and on table, of course, ST segment analysis of the ECG, myocardial brush grade, TIMI flow of the vessels, or the TIMI frame count. That is very important. If you see this slide, there is hypo enhancement there. It doesn't work. Okay. You can see an hypo enhancement, which is a yellow arrow, and then later it causes hyper enhancement. So the outcome of this patient, as you see, if you have microvascular dysfunction, they're going to do fare much worse than the people who have no microvascular dysfunction. So no reflow has late sequelae. Even the TIMI perfusion grade, if you see TIMI grade 3, grade 2, grade 1, grade 0, grade 0 has the highest mortality and grade 3 has the lowest mortality. So we have to establish flow quickly and a brisk flow. And this is a major problem that we all face, thrombus, intracoronary thrombus. It's a predictor of no reflow. It's a predictor of distal embolization. It is going to cause abrupt closure. It's going to increase MACE. Then come the drugs. We have multiple drugs which are recommended. Adenosine is one of them. It is shown that intracoronary adenosine before and after balloon inflation, given at doses of 24 to 48 micrograms, does reduce no reflow significantly, although in-hospital mortality shows a trend towards the lower part, but is non-significant in this trial. And it's very simple to prepare. Just take one vial into a 1 liter bag and you split it. Your ml will be 6 microgram per ml. Similarly, intracoronary versus intravenous abciximab for PCI and ACS. Again, intracoronary seems to be superior to intravenous abciximab in PCI. And the reason being, it facilitates diffusion of the drug into platelets inside the thrombus. So you have a local concentration of antibodies which can act against the thrombus. So there's improved dissolution of thrombus and there's improved dissolution of microemboli. Similarly, high dose intracoronary adenosine in saphenous vein grafts PCI, when I mean high dose, means more than 5 boluses, has prone to show significant reversal of no reflow. Similarly, high dose verapamil, we are always worried of using high dose verapamil, 1 milligram in 10 cc, 0.9% normal saline over 2 minutes, because we are worried that it's going to cause AV blocks, grade 1, grade 2, grade 3, but they are generally reversible with atropine. Similarly, this is the least used drug I feel in intracoronary no reflow is the use of epinephrine. A single bolus of 50 to 200 micrograms has been shown in patients to significantly help reverse reflow. The reason being, most of the no reflow we see are hypotensive in the MI situation. And when you have a hypotensive patient, your intravenous inotropes may take some time to get you adequate pressure. And if you don't have an adequate pressure, so you're always resistant to use nitroprusside, adenosine, you're always worried what is going to happen to the blood pressure. Wherein this drug, we can safely use even in hypotensive patients. And local drug delivery, you have very clear catheters now where you can diffuse the drug while inflating the balloon at a low atmosphere, a clear way catheter. The concentration is 100 times more compared to IV infusion. And what are the suggested intracoronary vasodilators for no reflow? Verapamil, remember the doses is boluses of 100 to 200 micrograms up to 4 doses, can go up to 1 milligram, which I showed you. Adenosine boluses of 20 to 60 micrograms, you can go as high as 2,400 micrograms. Sodium nitroprusside, boluses of 100 microgram, can go up to a total of 1,000 microgram. Nitroglycerine, 100 to 200 micrograms, up to 4 doses. But the nitroglycerine is the weakest of the lot. It's really not the one that is going to help you prevent no reflow. Epinephrine, intracoronary dose of 50 to 200 micrograms. Intracoronary epinephrine, if patient is hypertensive, is very effective. And as Dr. Shetty said earlier, he gave urokinase. Intracoronary TPA, 10 to 20 milligram in a thrombotic lesion, also helps in preventing or reducing no reflow. This is a trial which designed comparison of diltiazem, verapamil, nitroglycerine against each other, and also use of microcatheter versus guide catheter. So whether should we give it through the guide catheter or should we give it to the microcatheter? What they found, if you use a guide catheter, the average TB flow was 2.3 to 2.5, and the least was 1.8 with nitroglycerine, and that was not significant. So nitroglycerine intracoronary was 100% not significant, although the others were significant compared to each other. But if you use in the microcatheter group, the TB flow goes up to 2.9, 3, and even nitroglycerine goes up to 3.5. So clearly tells us that use of microcatheter is mandatory to reverse no reflow. Similarly, the same thing with the frame count in the guide catheter group was higher with diltiazem and verapamil, and nitroglycerine was the highest, 53. The moment you switch it to microcatheter group, the TB frame count goes down. So 26 with diltiazem and 39 with nitroglycerine, again reaching significance. So coming to management of no reflow, the most important thing that we forget, because our patients are going to be hypotensive most of the time, and especially if it's an anterior wall, he's giving you no reflow, he's going to be 70 systolic, 80 systolic. So maintain a normal blood pressure and rhythm. We have to concentrate on blood pressure and rhythm. So use judiciously inotropes, if required, use an intra-aortic balloon pump, because that's also going to be an adjunct to preventing no reflow. Watch the rhythm, get the rhythm right. If he's an AFib, make an attempt to convert him if he's acute AFib. So we have to have a sinus rhythm to get better outcomes. Exclude mechanical causes for impaired reflow, whether there's a dissection, whether there's a thrombus, if there's a spasm, administer nitroglycerine. Check ACT. This is commonly we miss. In fact, recently we had an operator come from Japan, and he was so diligent that every 30 minutes he was watching the ACT. He kept aspirating and sending for ACT and keeping the ACT above 300 in a chronic total occlusion, because they have two catheters. So we have to be watching our ACT and heparin, because in that moment we just keep forgetting that the ACT may be lower and that may be contributing to the no reflow. Glycoprotein 2B3A should be administered for beneficial results. Antiplatelets, which are given intracoronary, are generally preferred. Vasodilator agents via intracoronary route only, preferably microcatheter. How do we prevent knee flu? Anticipate the problem. That's most important. As I told you, most of our MIs are going to come late. They almost never reach in the golden hour. So they are the ones who will generally have no reflow. Avoid predilatation as far as possible. Thrombectomy has helped in acute MIs. It's still controversial, but I think it's a good tool, so at least you know whether it will help, whether you need to stent or you don't need to stent. If necessary, predilate at lower atmospheres with a smaller balloon. Avoid post-dilatation of the stent as far as possible. So deploy it at the highest possible pressure you want, and then not try to go in and take another NC balloon, unless, of course, it's under-deployed, then you have no choice. Use thrombus suction pre and post as per thrombus load. Because many a times you might get slow flow or no flow after putting a stent, And all you do is take a run of a thrombus catheter down, and you might have this flow completely restored. And in fact, these catheters also can be used in a different way. If you have taken your thrombus suction catheter below the lesion and take a shot, the reflux of the contrast will tell you how the distal vessel is and might show you a dissection at the distal edge of the stent, which is causing the no reflow, the supposedly no reflow. So your first stent may have caused a distal dissection which is preventing flow. So an injection, or I will show you another technique where you can find out what's happening. Judicious use of drugs, preferably by microcatheter, maintain the diastolic blood pressure to augment coronary flow. That's very, very important. So maintain your diastolic pressure higher to augment coronary flow. Be persistent. Use frequent high doses of vasodilators. NTG is generally not effective. Nitroprusside is potent and longer acting. This is what I was telling you. Can we run the first one? Yeah. So this is a case of similar to the one Dr. Shetty showed you. But mind you, this is not an acute coronary syndrome. So we put an IVUS probe. We'll show you why. Can you run it, please? There's the pre-dilatation. There is some flow, but still not great. Next, please. Can we run? The first the angio and then the IVUS. The first the angio only. So you see almost slow flow, no flow at all. Can you run the IVUS now? So what IVUS tells you that the distal vessel is normal. There's nothing there. You see that? It's clear, absolutely clear. And as we pull back, you start seeing a leaf plaque, some amount of dissection, and then you can see a proper dissection here. So what it tells you that dissection in this case was causing the no reflow. So all we had to do, we saw where the dissection ended on the fluoroscopy with the IVUS probe. Next, please. And all we had to do was deploy a stent. So an imaging tool helped us to decide what would be the strategy. Otherwise, we would have kept giving nitroglycerine and everything else, and maybe or may not have helped. And all we did was we deployed a stent up to the level the dissection was based on the IVUS probe, and this is the end result. So to conclude, I would say no reflow is a problem in acute myocardial infarction, and we really have no clear answers what to be given, what not to be given. Each has his own individual practices. Each one knows what is best for them or in their lab. But the ultimate aim should be that we should be persistent and not let the patient off the table till we have established good flow. Because many a times we just leave it at TME0 or TME1 or TME2 flow. There the outcome would be really not great. Thank you.
Thank you all. I would like all the speakers to come on stage and take the questions from the audience.
I think we can start with Dr. Mehta. If you can just stand back, we will finish off the questions from the audience. It's a very interesting topic and very dangerous situation which most of us face in the cath lab. Mostly associated with acute coronary syndrome, but also just now he showed that situation where you saw no acute coronary syndrome when you have no reflow, and all of us will be sweating. So let's start the questions.
Nicorandil is used many a times, but there's no great data on Nicorandil. But people do use Nicorandil. It works with many people, but there's no great data on Nicorandil. The predominant drug, I would still say, would be nitroprusside, adenosine, and the underrated epinephrine.